Hello, everyone. It's Kerstin here. I think I'm starting the meeting now. I can see we've got 33 participants already dialed in. I might just ask Valeria to give me the all okay to get started. Valeria is our Zoom host.
Perfect. You can start.
Lovely. Thank you. Okay. Welcome again, everybody. Thank you for registering to participate in our session today. I believe the session is recorded, so be aware of that. And we have three presenters today. We will all present for about 15 minutes after a quick introduction by myself. So that gives us time at the end for Q&A. So you can please just hold on your questions until the end, or you can type in questions into the chat room. Valeria will collate those questions, and then we'll have time at the end to discuss. So our three presenters today are Rebecca. Rebecca is waving at us. Hello, Rebecca is dialed in from New South Wales. She is a sustainability manager with Cleanaway in Sydney and is responsible for New South Wales and ACT. Rebecca is a very, very passionate educator and advocate for sustainability and waste management in the community. And she has a special interest and introduced a lot of great activities in the healthcare waste sector. And we'll hear great things from Rebecca soon. And then we've got Dr. Jess Davies. Jess is an anaesthetist in Melbourne. Jess is very, very active in the sort of clinical and healthcare related sustainability sector. Jess is the co-founder of Trash. It's great. I used to be called the Trash Queen, so I like Trash. So Trash stands for a trainee-led research and audit in anesthesia for sustainability in healthcare group. And Jess is also a PhD student at the moment, and she'll be talking specifically about one of the main sectors of waste and hopefully circularity, which is the pharmaceutical waste. And myself, I'm an anaesthetist too. I work at the Royal Brisbane and Women's Hospital in Brisbane. I've been interested in campaigning and advocating for sustainability in healthcare for more than a decade. And finally, we have a lot of traction in that area. And I'm very pleased to see that hospital and health services and governments are engaging and are really full steam on to capture sustainability activities, CO2 emissions, wanting to meet targets. And I've looked through the participants list. There's greatly a lot of participants from healthcare services and from governments. And I would like to advocate that all of you in your sustainability groups, in hospital and healthcare services, in governments and other agencies, please engage clinicians. I see, unfortunately, clinicians left out from all those advocating and governance groups. The clinicians have been in sustainability activities in healthcare for decades. They're very knowledgeable. And what I unfortunately see is that many clinical activities are not captured. This could be value-based healthcare, choosing wisely, pharmaceutical waste, medication reduction. So please, my plea to you, engage and get your clinicians on board in your committees. So I'll get started. I will talk about, firstly, very briefly, give you an overview on the environmental footprint of healthcare. So the global net CO2 emissions worldwide are about 4.4%. Australia is performing a little bit worse, so CO2 emissions from healthcare are believed to be around 7%. The majority of that is contributed to by public and private hospitals. Australia spends hundreds of billions of dollars on healthcare and does emit a lot of CO2. As you can see here, that's from 2014-15, an estimated 36,000 kilotons of CO2 emitted. I personally believe this is grossly underestimated, as we are only just starting to capture or to try to capture CO2 emissions from healthcare, and we are not really there yet to have great visibility over all aspects of CO2 emissions from healthcare, particularly from the clinical areas. And there's not that much guidance, but some guidance from international data and literature. So healthcare waste is very big. Healthcare waste was very a long time underestimated, underrepresented, and was just probably not on the radar of many people. But Rebecca will tell us that she's always been interested in and started great activities. As we have a growing population, we have an aging population, so waste from healthcare will just ever increase in the future. Operating theatres where Jess and I work are producing about 30% of all hospital waste, and if segregated and separated correctly, 70% of that waste is recyclable, which is mainly contributed to by plastics we're using in healthcare. It's with pleasure that I see that healthcare industry making great efforts to enter a circular transformation of their businesses, and we'll hear about that from our presenters today. Australia's carbon footprint, as I said, 7% of the net carbon national emission worldwide. We are amongst the 10 largest emitters of CO2. And so we are amongst very large countries, amongst the European Union. They incorporate 27 countries and have 747 million people living. So us with our 25 million, I think it's quite astounding that Australia is amongst the 10 largest CO2 emitters in the world. And on the right-hand side, you see just again a little composition of healthcare, what healthcare means. So the majority is hospital-based, and then pharmaceutical waste, pharmaceutical areas, and then the other little areas contributing all to the global sort of conglomerate of healthcare. This is a graph which represents more precisely CO2 emissions by capita. So, and that's where I think it's a very shocking representation of Australia, that as a very small country with only very few people living in Australia, our carbon footprint is that much that we are scoring second largest CO2 emitter from healthcare per capita. And that's just another graph. So there's a lot we need to do to improve our CO2 emissions, and circularity certainly is one aspect of that. I'll be starting my talk, and I am going to talk about polyethylene terephthalate, PET, a treasure to be recovered. So PET has been close to my heart for quite some time. We use PET in healthcare, and particularly in hospitals, particularly in the surgical and the interventional areas a lot. So I'll give you a quick overview of the PET for packaging used, which is mainly thermoformed PET. I'll give you a quick estimate on the volumes to be recovered from Australian hospitals, talk about the PET demand globally and nationally as a recyclate, and then give you a quick outlook on circularity of medical device packaging. Photo on the right is all the recyclables from one surgical procedure. I've just put that there for you. So you see that the majority on the left-hand side, sort of separated, of that waste is from plastics. And as per an Australian publication, 40% of all plastic waste from the operating theatres is PET. And the PET I'm talking about today, you can see in the bottom of that picture, all that very transparent, beautiful packaging for mainly single-use sterile surgical instruments. So on the left-hand side, you see our packaging. So that's a box with a surgical instrument, which in which this thermoform molded PET box sits with the instrument in it. We know that PET takes about 700 years to degrade in landfill. And unfortunately, I would estimate that up to 70% of all those PET packagings from hospitals end up in landfill, as we actually have no mandate and we have no concept for needing to recover certain plastics from the operating or from interventional areas. This is specifically useful as a plastic because it never touches a patient. It remains very clean and unsoiled. So in the middle, you see one of those packaged single-use surgical instruments, which in itself go into waste. PET is favored as a packaging material and thermoformed to keep those instruments very stable. They don't get damaged on transport. It's very light, it's rigid, it's transparent, and most of all, it is virtually impermeable to all microorganisms, and therefore it is an ideal product to package sterile consumables or instruments in the healthcare sector. This is how we do it. So we have little posters in our operating theatres to educate our staff on how to separate the box into card box, recycling the PET into a separate stream. And that's what we have introduced in our hospital at the moment. We separate PET at source, separated from all other commingled waste, and I go into that in a minute. This is an audit we performed in our own institution. Over 4 weeks, we measured all PET coming from the operating theatres, and as you can see, over 4 weeks and over different days of the week, the volume of PET recovered is quite variable, and that depends on the surgical procedure performed and on patients operated on that day. In total, we collect as a hospital. We are a very large tertiary hospital with about 28,000 surgeries per year. So we collect 20 kilos of plastic waste per day from our operating theatres, and about 50% of that is polyethylene terephthalate. As per publication about 8 years ago, this was estimated to be 40%, and of course there's variability there. As you see on the left-hand side, the photo demonstrates different sizes and forms of that PET, which when it gets to potentially a recycling facility would impact the recyclability, just as one aspect, size and form. So our estimate from our operating theatre is that we would produce about 2,000 tonnes just from the operating theatre, incorporating all the other interventional areas. Our hospital would produce 3 tonnes per year. This is not a lot, and as anyone who works in waste management or the recycling industry would know that this is not a lot. So strength comes in numbers and volume. If there would ever be a scheme, which I had always dreamed of, to have PET separated at source and have a single source recovery stream, that would probably need to become a statewide or even a national scheme to have the volumes needed. But with 1,300 hospitals in Australia, or with, I believe we have 2.8 million surgical procedures and 1.5 million interventional procedures where those products are used, that would probably give us strength in numbers and would probably ask for a national scheme, and I'll talk about that in a minute too. So what are the barriers to actually recover thermoform PET? The PET we all know is the bottled PET, for which we now have a statewide and national recovery schemes introduced by the industry themselves. And the PET from those bottles is very different to the PET of thermal-formed materials. It is not as highly recycled as we would like it to be. It behaves very differently in the reclamation process than bottles. So therefore, the mixed baling of thermoformed and bottled PET currently is only allowed or sort of favorable in a 5 to 10% mixture of thermoformed PET into bottled PET balings. Another barrier is our MRFs, so the material recovery facilities. If they are modern, equipped with optical sorting capabilities, and they have capabilities to sort and detect PET from other plastics. However, I believe many of Australian recovery recycling facilities are rather ancient and have more manual recycling options, and in those facilities, most likely PET will end up in commingled waste, if it's separated at all. So therefore, separation at source from hospitals is probably the way to go. And I know in the United States, there's big movements to increase the recovery of thermoformed PET, because with their recycling rate of any PET is still very low, but it is acknowledged that the quality of thermoformed PET in comparison to bottled PET is much higher, and therefore the recycling potential also higher. So how to overcome barriers, particularly to recover PET, particularly from healthcare? You need to advocate. This product is in use, and this product is a good plastic which needs to be recycled. And I know people like Rebecca are advocating and educating hospitals, and we try our best to let clinicians know that those plastics are worthwhile to be recovered. Currently probably going into commingled waste, but maybe in the future we would find a separation process, and I'll talk about our own little trial in a minute. We need to overcome misconceptions. There is a lot of misconceptions out there to use recycled plastics, recycled PET from healthcare. So our PET would most likely be suited to be used in agriculture or in hospitality or in the food industry to produce clamshells. And I have been told that our Queenslander farmers would not be keen to use any recycled PET from hospital for their farms. So there's a bit of education needed to overcome those misconceptions, probably. And then, of course, there's always challenges in separating, collecting, and transporting any at source separated products. What we probably need most is engagement from the producer of those plastic products and packagings, which is product stewardships and extended producer responsibility, which is all evolving at the moment. And anyone in sustainability in healthcare would know that procurement is really one of the main factors we are targeting at the moment in terms of sustainability. And I'm hoping, and I'm in discussion with one of the main contributors to that PET from the healthcare industry to see what they could contribute. So I'll give you a little outlook on circularity of that PET product with our own LCA. So we've done a life cycle analyses to assess the potential end life pathway for that beautiful plastic from healthcare, and we've used the ISO 14040 methodology for life cycle analysis. Data are unpublished currently, but our results very strongly indicate that there's a strong reduction potential of the environmental impacts by recycling PET in its own separate stream rather than going to landfill or into commingled waste as the comparators. So yeah, as I said, it's probably best used in production of clamshells for food industry and the cosmetic industry and any other industries. And anyone who's interested, we'd like to explore further the market for PTE from healthcare. This is what we're doing at the moment. So on the left-hand side, our plastic PET per patient, per procedure, collected into bags. Those bags go into a separate PET labeled bin. And at the end of the week, we transport that PET to a Brisbane-based plastic injection molding manufacturer. It's a brand new, you see very clean floors, a brand new facility. And they wish to specialize in plastics from healthcare and are very, very grateful. We separate the PET at source for them. And we are kind of in a trial phase to explore chemical suitability. So PET from healthcare, the ones we talk about, very easily is transformable into terephthalic acid, so which is the structure it's built of. So that's a good sort of chemical background, but also it's easily shredded and pelleted. So we are hoping to close the loop and produce a circular product which will most likely go into agricultural use. And I'll keep you updated on that. That's the end of my talk. Thank you. I would like to invite Rebecca now to present her talk. I might just stop sharing.
Sure, no problem. Let me share mine. Oh, I can't share while you're sharing. Wait, being impatient.
Stop. Yeah, I have stopped.
There we go. All right. Now I need to change this to slideshow. There we go. Can everybody see that okay? All right. So as Kerstin mentioned, we've sort of been puddling around in the same circles for a little while, pursuing a lot of the similar topics. So just to give you, oh, sorry, I forgot my acknowledgement. So I'd just like to acknowledge the traditional custodians of the land that we're all dialing in from today. So for me, that's the Darkinjung people on the central coast of New South Wales, and pay my respects to elders past, present, future, and acknowledge any Aboriginal people who are in attendance today. Just to give you a little bit of background on Cleanaway, because like I said, like Kerstin said, I'm from a slightly different background than our other presenters today. We're a big waste management company, if you haven't heard of us, and we have lots of different customers in lots of different industries, and one of our arms actually deals with healthcare. So we service a lot of hospitals and things nationally. I'm just based in New South Wales, but we do have reach all across Australia. I won't dwell on this too much because I think you covered it really, really well, Kerstin. So a lot of waste is produced in hospitals. At the moment, a lot of it goes into the general waste. Some of it might make it into the commingled, as we were discussing. Quite often, plastic items also end up in the clinical waste. So a lot of these things end up in places where they're not being recovered or recycled. Mostly they're single-use plastics for cost and hygiene reasons. So it's not one of those things where we can necessarily put in a reusable item like we would in a food court, for example. The disposable plastics there, we would just say, okay, can we use ceramic plates and wash them instead? So it's not really feasible for that. Kerstin touched on the fact that there's problems in MRFs. So in addition to the, yes, somewhat archaic machinery, quite often the materials aren't the right size or shape. So they're either too small or too big or too flat or whatever, that the MRF can't deal with them. So MRFs are designed to deal with PET bottles, for example, not big sheets of flat PET like the thermoformed. So unfortunately, a lot of this ends up in places other than where it can be recycled. There's a lot of problems from a practical perspective. So Kerstin touched on some of the perceived problems. So a lot of people think that, oh, waste from hospitals, that must be contaminated with blood and body parts, and it must be dirty, and, you know, it must have problems. We don't want that. But there's also some problems from a hospital perspective in terms of just sheer logistics of putting in some of these different services. So space for source separation and waste storage is a real issue. Hospital staff are time poor. Waste management isn't always a priority. I know that's a generalisation, and lots of people here are really, really into it, and that's fantastic. There's also misconceptions about what can be recycled and actually what constitutes clinical waste. Every time we go to a hospital and speak to someone different, they have a different idea of what should be clinical and what shouldn't be clinical. And then even within the industry, there's different perceptions on what constitutes clinical and non-clinical waste. There has been historically a lack of interest from processors in waste from hospitals. They have worries about, you know, health implications, like will there be sharps mixed in? And in general, at the moment, it is a little bit more complicated because the recyclables need to be separated by polymer, so that's the type of plastic, and also by the form. So we need to have the PET separate from the polypropylene, for example, which is PP. And then if there's different formats of it, so flexible or rigid or woven, multi-layered, it all needs to be separated. So that makes it additionally complicated for hospitals that don't want to have 10 different streams of their recycling. Also, we found that not a lot of items are clearly marked. So they might have a plastic coat on them, or they might not, or they might just have a 7, but they're actually 90% polypropylene. So the labeling on the items isn't as consistent as it would be with consumer items that we encounter in people's homes. But there's a lot of potential there. You know, cost savings for the hospital in terms of getting things out of general waste, out of clinical waste, and into recycling, because both of those streams, general and clinical, are very expensive. Environmental benefits for the hospital. Also staff engagement, because quite a lot of the time, you know, you'd speak to people in hospitals or in healthcare settings, and they're very frustrated that all of this stuff is just going into the bin, into the general waste, especially if they do their best to recycle at home. So we had been working with a number of our customers on little freestanding case studies. So we knew that there was potential. We knew that there was interest. And so some of the really motivated customers, we just did some pilots. So we did one at Sunshine Coast University Hospital to recover polypropylene IV bags with Fresenius Kabi, who are a manufacturer of those bags. And we did a couple of trials with Gosford Private Hospital here on the Central Coast for rigid theatre plastics and also for clear soft plastics. And they were really successful. So we managed to source separate them. Contamination was pretty much non-existent. And we recovered, you know, good amounts of the product over a period of time. So I guess the idea then was, okay, we know that this can work, but we really need proof of concept so that we can prove to the recyclers, so we can prove to larger hospitals, so we can say, actually, no, this works, and it works at scale, because that's always the problem. There's often lots of really great solutions out there and technology, and these things can be recycled, but scaling it and making it commercially viable are the real pain points for us in the industry. So we decided to try and do a larger trial with multiple hospitals to provide proof of concept that this could be its own separate recycling stream. So what we decided to do was apply for a grant. So the New South Wales government had a lot of different grants available at the time. We applied for a Circulate grant. It was initially a 12-month grant that ran from the 30th of June in 2021 until the same time in 2022. We plan to target around about 8 hospitals and recover about 100 tonnes of different plastics from primarily the theatres using source separation bins and colour-coded stands. The soft plastics were to be baled on site if we could, and then we were going to use our existing network of trucks to collect those, bring them back to a consolidation point, and then send them to the recyclers. So it sounded like a pretty simple idea. And then unfortunately, the second wave of COVID hit and it slowed everything down. So implementing the program into hospitals was really difficult. We had a lot of hospitals saying we're really keen, but you know, we just can't at the moment. We don't have the bandwidth to do this. We couldn't install equipment until the health orders allowed us to. And then in terms of training and staffing and just staff taking on any more mental load during COVID, it just wasn't feasible for us to progress with some of the hospitals that had already signed up. So what we did is we got our project extended, and it's actually been extended again since then. just due to difficulties with, I guess, uptake and it taking a bit longer than we thought. And also, like Kerstin said, the tonnages can be quite low in particular hospitals unless you get some really big ones. So it's just finding the right hospitals that have got the really big tons and collecting those. But luckily, our project's been extended again until early 2023. So now we feel like we're pretty well on track. We ended up getting the plastics processors to collect it for us directly. We collected it bagged in bulker bags or baled, and then we increased the amount of items that we were targeting because like we barely scratched the surface in terms of the types of plastics that are used in hospitals. So every time we spoke to a new hospital, they were like, oh, what about this or what about that? So results so far, we've got 5 hospitals at the moment, and we actually have a new collection trial due to start very early next year with one of the local health districts in New South Wales, which is really exciting. So that'll be a whole lot of hospitals coming on board together. And I think that that will be the thing that we need to really sort of kickstart this and have a really robust program. And in that one, we're actually looking at the feasibility of which plastics can be mixed together. So can we put rigid polypropylene and woven polypropylene in the same stream rather than having to separate them? And that makes less work for the hospital staff, which is really important. So our first collection started in February of this year. We're getting there slowly but surely. I think it's gone up a little bit since I wrote this presentation last month. We're sort of hovering at around sort of 20 to 30 tonnes at the moment. With it just increasing as we go, and there's a little bit of a lag in the data that we get, so I think it could be a little bit higher than that at the moment. The types of things that we're collecting, so flexible polypropylene including IV and irrigation bags, obviously not the PVC ones. We're targeting polypropylene bags and including the packaging on the outside because that is recyclable too. We're including things like sterilisation wrap, disposable curtains and linen, and we're working with some of the manufacturers of those things as well to make sure that we can get those recycled because even though they're not very heavy, the volumes of those are just phenomenal from hospitals. Rigid polypropylene, so things like kidney dishes, saline bottles, wash bowls, all of those sorts of things. Also breast milk collection bottles, which weren't even on my radar, but they're apparently made of polypropylene and they're beautiful and clean by the time we get them. The rigid polypropylene, PET packaging that Kerstin was talking about, and also low density polyethylene, which is basically pallet wrap or other sorts of bags that are flexible and clear and you can sort of stretch with your thumbs. So that's what that is. And that's baled separate. That's always had a pretty good market, but I think it wasn't being collected from hospitals like it was being collected from other commercial customers like warehouses, for example. So that one's not really as difficult, but it's something that hospitals haven't necessarily been exposed to before. You can see here some of our nice educational signage that we've put together as a result of the grant. And hospitals can choose which streams they want to do. So something that we're finding as hospitals sign up is they might go, okay, we're going to go with the sterile wrap first, and then we'll introduce other streams. You know, they just want to start with introducing one at a time, and that's fine. It just takes a little bit longer for us to get along. So a lot of hospitals are introducing the sterile wrap first, and then maybe the IV bags, and then maybe the rigid polypropylene. And that's one of the reasons why we're looking at what we can mix together, because it would make it a lot easier to get more volume.
Rebecca, I think you just wrap it up.
We'll wrap it up. Okay, wrap it up. So there's been a lot of challenges. Logistics, time and safety, as we've said, quite often a perceived risk rather than an actual risk. So there's a perception that there'll be sharps and there'll be biohazardous waste, and there isn't. Also approval delays by hospital WHS. I'm sure I don't need to tell anyone on this call how siloed hospitals can be, and it can be really hard to find the right person. You might have one person who's really keen, but you know the rest of them aren't. And these are some of our learnings to date. So be agile. We had to change our collection methodology multiple times, work with the stakeholders to find solutions, especially the champions. So, you know, if we can find a champion on a site, it is much more likely to get up and keep going. It takes a lot longer than you think. We've had to extend our grant twice, but we will get there in the end. I'm very confident. Regional areas are still a real problem, and that's something that we're really looking at the moment, because we've had a lot of regional hospitals that would love to get on board and haven't been able to, and that the education piece is absolutely mandatory. You can't put in a new service if you don't educate everybody on how to use it. And that's it. Sorry, I think I went over time.
Thanks, Rebecca. And
sharing.
We'll have Jess's presentation in a minute.
Yeah, I'll just share my screen and see whether you'll get the right view. Have you got the main view?
We've got your presenter view with your preview.
I'll just screen just swapped around. Oh, that's still not working. It won't let me.
That's okay. It's your presenter view.
Okay, well, thanks for having me and thanks for inviting me, Kerstin. And definitely echo your sentiments to involve clinicians, because there is a lot of people interested in not just resolving our waste issues at the end, but certainly about exploring how we can change our models of care to be more environmentally sustainable. So I thought I'd briefly talk about pharmaceutical waste because it is a really challenging area to navigate, and it has been for me. And I guess because it's a circular economy, I think it's really challenging to see how it could be circular, and I'm interested to hear some of the audience comments. I don't have any conflicts of interest, but I have several roles, and unfortunately don't get any money from any of them. And we're all familiar with this image, which is the carbon footprint of Australian healthcare according to healthcare expenditure. And I think very little attention really is paid to this pharmaceuticals, which is 1/5 really of our carbon emissions from healthcare. And I think because it seems just really difficult to tackle, we don't really understand why it's so high. Maybe it's the packaging, maybe it's the drugs, maybe it's the volume, but it is pretty consistent across other healthcare systems that have carbon footprints as well. We know that pharmaceutical APIs, which is the active pharmaceutical ingredient, do have a high carbon footprint. Certainly from within anaesthetics, which we use a cocktail of multiple drugs to keep people safe during various kinds of surgeries. The carbon footprint of many anaesthetic drugs has been elucidated, at least from a pharmaceutical ingredients perspective. And you can see that there's a very large range between succinylmethonium and dexmedetomidine, but of course that is relative to the concentrations and dosage that we use from them. What's interesting is that the greenhouse gas emissions correlate to the number of steps required to synthesize the drug, not necessarily whether it's synthetic or like a natural ingredient, if you will. For example, morphine is the second bottom green one, which is largely a naturally occurring drug. And that has a very high carbon footprint because it requires a number of steps. Likewise, there have been some life cycle analysis of pharmaceutical drugs, particularly mostly intravenous ones, but there are some of tablets, demonstrating that although it takes a reasonable carbon footprint to create the pharmaceutical ingredient, the main issues come with production of the packaging and assembling of the packaging as well. And this was from an LCA of ibuprofen given to a patient in Germany for 4 days. Interestingly, though, it's not always just about the packaging, and it does depend on what the contents of the pharmaceutical item contains. This is an inhaler, typically used for asthma or respiratory problems, and most of these type have a greenhouse gas propellant agent, which makes them have a very high carbon footprint because they're releasing carbofluorine. CFCs, I was going to say the wrong word. Someone in the audience will definitely correct me. So releasing propellants to utilize the drug in this, this delivery system. And I guess one of my main points is that we have the ability as clinicians to change the carbon footprint of our prescribing practices, which then removes the need to not removes the need, but reduces the need for mopping up the carbon footprint of our decisions. Because if we make better decisions at the start, for example, using an inhaler on the left-hand side, which is powdered and doesn't use a CFC propellant, then our carbon footprint is much lower. And to give it some context, the carbon footprint of one of these inhalers is like recycling 210 kilos. And one of these ones on the right-hand side is about 300 kilometers driven in a petrol car. So although the recycling benefits are there, really it does require a carbon footprinting approach sometimes to pharmaceuticals. No more obvious than in anaesthesia. These are two anaesthetic volatile gases that we use to keep people asleep. The left one is called sevoflurane, and the one in here is called desflurane. The main difference is that although they're both safe and they could be used on a variety of patients safely, desflurane has a very high carbon footprint because of its global warming potential, and one bottle is equivalent to nearly 900 kilos of carbon dioxide equivalents, the same as driving nearly 6,500 kilometres in a car compared to 300 kilometres in a petrol car. And so another example where clinicians have an opportunity to change their models of care to a lower carbon footprint, and it becomes much less about the packaging and much more about the contents of the packaging. In terms of circularity with volatile anaesthetic agents, one of the arguments is that we could just capture all the volatile gas that patients breathe out from the anaesthetic machine into one of these pipes and store all of the gas and recirculate it for another patient. But unfortunately, although it is owned by Baxter, the company that produces desflurane, there's currently no license to reuse volatile agents in any of the countries where it's available. And unfortunately, in a recent study, it was only 25% effective at capturing the volatile agent. And given the carbon footprint of desflurane and its global warming potential, then you're still having a massive carbon footprint, massive CO2 emissions for using desflurane, even if you were to try to use a recapturing device for creating a circular economy, as it were, with a volatile anaesthetic agent. So that's probably enough about the contents of pharmaceuticals. One study that I was planning to talk about is looking at the difference in packaging and the difference in our models of care when we're delivering some drugs that are available in oral or IV formulations. Paracetamol is the same as acetaminophen, and typically we give them as tablets. So of course, you can buy them at the supermarket or the petrol station, and a 1 gram dose is very standard. There is fairly good evidence that there is no difference between giving a patient an oral dose to an IV dose, particularly around the time of surgery, but that the cost for an intravenous dose, one of these ones in a plastic vial or a glass vial, is between 80 to 200 times more, so 80 to 100 times more than a simple dose orally, even though it's similarly effective. And of course, as you can see, for an intravenous plastic vial dose, which is a polyethylene vial, it has 100 mils in it. It also has a little container on the outside, and it also requires an IV giving set to be delivered for it to be administered to the patient. And similarly, a glass vial contains 100 mils. It is a far greater volume than just the paracetamol, and it also requires an intravenous giving set. So one of the questions was, well, if there's no difference to giving the patients oral or IV, is there a carbon footprint difference between them, given that we already know the financial one? So filling in the third part of the triple bottom line. Now, we haven't published, so please don't screenshot my screen, but here you can see the carbon footprint, carbon emissions of 1 dose, given either as an oral tablet, as an oral liquid, like you might use for a child, although a 1 gram dose would be a large dose, and a plastic vial or a glass vial. And you can see that even though we may have a tendency to choose something that's non-plastic, for example, glass, because we perceive it to be recyclable, it actually has a far higher carbon footprint just to manufacture and dispose of. And so I guess it's really important to make sure that we know the data that we have and whether we continue to make the best decisions, not just based on reducing plastic, which is obviously an admirable goal. Interestingly, creating the pharmaceutical ingredient that's active is basically the same for all of the oral and IV. It's slightly more for IV, but not much. It really comes down to the packaging and administration supplies, which of course is the IV giving set. For this one is the small syringe, and for the oral tablet, it is just a little paper container. We extrapolated these findings and worked out that with the hospitals that we audited in these 3 countries, that there would be pretty significant environmental savings if we just gave all of the oral doses all of the IV doses orally, and likewise the financial savings, which are fairly well documented before this. And so one of the models of care that we propose is that for elective surgical patients, why don't we just give patients oral instead of IV? The financial saving, no difference in safety, and it's a much smaller carbon footprint than IV formulations. Some of the interesting parts that have come out of this study, though, is that pharmaceutical waste is highly regulated. All of the environmental protection agencies in every state, although Victoria is slightly different, says that pharmaceutical waste must get incinerated, and that's the same in the UK and the US. And as is really important to destroy pharmaceuticals, including trace pharmaceuticals in the vial, because otherwise they may leak out of landfill, and there's multiple landfill studies demonstrating that pharmaceuticals are present within the leachate. And that's because we often perceive these yellow bins to be a sharps bin that we can put pharmaceuticals in, and actually we've audited 23 hospitals in Australia and found that the majority of them use a sharps bin for their pharmaceutical disposal. And you can see in here there's propofol syringes in there, there's pharmaceutical vials in there, along with proper sharps. And the problem with this is that sharps bins often don't get incinerated. They may get chemically treated and shredded and then buried in landfill. But if they contain pharmaceuticals, then those pharmaceuticals may leach out. One of the major pharmaceutical wastes that we have in anaesthesia is from running our anaesthetic drugs intravenously instead of using the gases that I showed you before. And they're largely contained within glass vials, some of which are sharp, but the majority of them that are used for longer cases are made of hardened glass. That's the same for antibiotics that are contained in here, antibiotic vials and paracetamol vials. That makes a large amount of waste in sharp bins that perhaps is the wrong place for them. And again, if we are trying to if we're not placing these in the correct things, then they'll leach into landfill. But one of the reasons that people frequently bring up about IV paracetamol and using glass vials is that they want to recycle them and perceive them to be more recyclable than a plastic vial. But as we saw from the life cycle analysis, actually the plastic vial has a lower carbon footprint than glass. And actually, I'm very happy to be corrected by someone in the audience, but recycling hardened glass is actually very difficult. What I've found is that they require heating to a higher temperature than normal, which has a higher greenhouse gas emissions to recycle. So they're typically not accepted by recyclers. And that an alternative use for them, which is crushing them into building additive as an aggregate, also can increase the greenhouse gas emissions because of the energy used to do that. And then, of course, if we are going to be recycling a pharmaceutical vial, then we have additional problems in preparing the container for processing, because we can't simply just send them a vial with trace pharmaceuticals in them. We also can't just empty it out into the wastewater where it will contaminate our landfill, our wastewater. So again, it comes back to what Kerstin mentioned at the start about low value care and really choosing wisely about the way that we deliver clinical care, because on the left-hand side, you can see that healthcare carbon emissions 80% come from delivering clinical care, which makes sense because that is our main business. But when we look at that clinical care, actually, 10% of that may be harmful. And 30% of that may be low value care, which is that care that is not good value for money or necessarily providing benefits to patients. And we really should be including an environmental harm factor into this, as well as patient and financial factors. So really, as mentioned earlier, clinical care has largely been ignored in addressing healthcare carbon reduction. And given that we are 80% of the carbon footprint of healthcare in clinical decision-making, clinical care delivery, then clinicians really need to be involved in reducing low-value care and choosing wisely in the way that they deliver it. And so my message would be to include actions to address pharmaceutical choices, the way that we dispose of our pharmaceuticals, and really consider the carbon footprint, not just the end use of our items like recycling, even though that is really hard. And I always finish on something positive, which is that even though things are really difficult and changing the carbon emissions of healthcare seems fairly large and insurmountable, everything starts small, and that a small change can make a big difference. And that it's great to see so many people engaged in making a difference themselves. And that is the end of my talk. I'll just stop sharing.
Thank you, Jess, and thank you, Rebecca, for your great presentations. We have a couple more minutes if you wanted to. I've just been given the okay by Valeria. We can go over a little bit. So I might just address some of the questions that have come through the chat, and then I'll open to the audience to ask us questions. PET can be recycled up to 10 times, and particularly that high value PET from healthcare. And then there was a question from Cindy to Rebecca regarding which hospitals are participating in the trial. And Rebecca has already answered that. Anyone who is interested, Rebecca, in participating, should they get in contact with you, or is it too late anyway because you're in the last phase?
No, we're looking at trying to continue what we're doing beyond the grant. So even if you don't participate in the grant project, because like I said, it'll be finishing early next year, we are planning on making this an ongoing waste collection stream for our healthcare customers in Sydney surrounds and broader New South Wales. So if you're interested, please let me know and you're in those areas. I'd love to make it national, but some more steps, right?
Yeah, great, fantastic. Okay, get in contact with Cleanaway and ask for Rebecca. That's the easiest way. Otherwise, send her a message.
Yes, stalk me on LinkedIn. That's probably the best way.
Yeah, that's good as well. And I wish you come to Queensland soon. So any other questions, please post them in the chat. And I just open the floor for anyone who wishes us to speak up. Just unmute and ask a question, please. Got some great feedback coming in from Kylie and Ali. It's good you learned a lot, Ali. That's great to hear. And excellent information from Kylie here. Anyone else? Otherwise, Rebecca, are you reading this?
Yes, to lab recycling, as long as it falls into one of our areas. We have actually worked with Victor Chang, I think it was, but in some of their labs, and we're working with CSIRO at the moment. So yes, to labs.
Yeah. I think anything kind of clinical waste was very much overlooked in the past and not considered so much in the waste stream. I don't know why that was, because certainly there's large volumes from laboratories and certainly hospitals and other healthcare facilities. Jess, will you be publishing your data? Yeah.
Yes, it just takes a long time.
Yeah. Jess, that's part of your PhD, isn't it?
Probably not actually. My PhD is more about implementing change into hospitals rather than life cycle analysis, but it's all in the same topic.
Great. Is there work to start pushing the suppliers to support solutions as we all similar suppliers? Yeah, so that's probably part of producer responsibility and product stewardship. In our healthcare sector, there is not much producer responsibility happening as we speak. We mentioned Baxter. Baxter was the first and is probably still one of the only healthcare industries partnering with the Vinyl Council of Australia to recover their own PVC. So that's a very well working and very worthwhile scheme, which works nationally. Baxter is the company providing fluid bags packaged in PVC bags, and they recover their own PVC. And we wish that more healthcare industry partners come forward to engage one way or the other. But the way procurement is moving, they will be probably forced needing to engage because their choices will change and procurement requirements will have a green tick. I don't think we know exactly how that's going to look like, but product stewardship will be one of the assessment criteria for procurement. Jess has just put through how they can be found as trash organization, the website and Twitter. That's great. And then Kerstin, in comparison of recycled PET, circular versus stainless steel items that are sterilized. No, that hasn't been done. And I think that's two different categories. What we're talking about, the PET, is the packaging of those instruments. So packaging is probably lower value than those instruments themselves. But there is, if I understand your question correctly, there's some research and actually already some data out there on the value of recycling, not recycling, maybe, repurposing metals in those surgical instruments. They contain not only stainless steel, but titanium and very, very highly sought after other metals. Yeah. Jess just posted some information on a webinar that Trash is hosting very soon.
Yeah, we have a webinar. It's called TrashCon next Thursday week, where some of our members are going to present some of their projects, and it's from 7 to 8:30 p.m. Eastern Daylight Savings Time, and it's free. You just need to sign up on our website or just go to our website at the time, and the link will be available there.
Coming back to Nicola's question regarding recyclability or essentially circular use of instruments, I think we've all, people as old as me would know that we used to have all single-use instruments. We used to have surgical instruments that got washed and sterilized and reused. Same with the dressings and the gowns and the surgical drapes. And then 20 years ago, the move was to move away from needing to use energy, needing to use water, needing to use soap, and harming the environment to all single use. And I think we've been probably misled a little bit by the industry, and we did not do due diligence to actually scrutinize the data, and that's happening right now. We are having a couple of publications and very good data on the advantages of going back to multi-use items, particularly in healthcare. And well, if you do a life cycle analysis, you always have to take into account where that analysis was performed. Australia always performs a little bit worse than other countries which are already using green energies. So all the data putting into a life cycle analysis are kind of affecting the outcome. And Australia, unfortunately, is still using a lot of brown and dark energy to produce items. So that makes it even less worth using single-use items in Australia. But all of those data in those investigations and studies are coming out and informing the public and clinicians and any other people interested. And that's not only just happening in healthcare, I think it's happening everywhere. Okay, I think we've got the wrap it up message from, I know that's just needs to go, all right. But I think we'll be wrapping up if there's no more questions. Anyone, please feel free to ask your last question before I close the session. Thanks all for dialing in, and thanks for being interested, and hope we can all make a big impact to stop climate change and prevent actually harm for our own environment and harm to our own health. Thank you all, and goodbye.